Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. Claw hand is a deformity caused by paralysis or severe weakness of the intrinsic muscles of the hand. The metacarpophalangeal joints become hyperextended, while the proximal and distal interphalangeal joints become flexed. It is most classically associated with an ulnar nerve palsy and mainly affects the ring and little fingers. To understand this deformity, first revise the important muscles and their nerve supply. The muscles in the hand include the lubricules, interossi, thinner eminence muscle, hypothenar eminence muscles, and long flexors and long extensors, which arises from forearm. The lumbricals flex the fingers at the metacarpophalangeal joints and extend them at the interphalangeal joints. Remember lumbricals as number icals because they cause flexion of the fingers, just like when counting fingers. The first and second lumbricals, supplying the index and middle fingers, are innervated by the median nerve. The third and fourth lumbricals, supplying the ring and little fingers, are innervated by the ulnar nerve. The interossi lie between the metacarpal bones. Remember interossi as interdigits muscles, and they cause adduction and abduction of the digits. The dorsal interossi abduct the fingers, remembered by DAB. The palmar interossi adduct the fingers, remembered by PIAD. All the interossi are supplied by the deep branch of the ulnar nerve. The thenar eminence is the medium loaf-like muscle mass at the base of the thumb. It includes opponens pollicis, abductor pollicis, and flexor pollicis hemisucles, causing the given movement of thumb. Remember that we are calling it a loaf because these three muscles, along with the lateral to lubricants, are supplied by median nerve, while the rest of intrinsic muscles of the hand are supplied by ulnar nerve. The hypothenar muscles control movements of the little finger and are supplied by the ulnar nerve. The long finger flexors arise in the flexor compartment of the forearm. Flexor digitorum superficialis is supplied by the median nerve. The lateral half of flexor digitorum profundus, acting on the index and middle fingers, is supplied through the anterior interosseous branch of the median nerve. The medial half, acting on the ring and little fingers, is supplied by the ulnar nerve. The long extensors arise in the posterior forearm and are supplied mainly by the radial nerve through its posterior interosseous branch. The useful summary is that median nerve supplies loaf, while the ulnar nerve supplies most of the other intrinsic hand muscles. The long flexors have mixed median and ulnar innervation, while the long extensors are supplied by the radial nerve. Now consider the pathophysiology of an ulnar claw. An ulnar nerve lesion denervates the interossae and the medial two lumbricals. The patient therefore loses normal metacarpophalangeal flexion and interphalangeal extension in the ring and little fingers. The long extensors are still functioning, so they pull the metacarpophalangeal joints into hyperextension. The long flexors, flexor digitorum superficialis and flexor digitorum profundus, remain active and pull the interphalangeal joints into flexion. Therefore, ulnar nerve lesion leads to intrinsic muscle paralysis, which leads to unopposed metacarpophalangeal extension and unopposed interphalangeal flexion, producing the ulnar claw. The claw is usually more obvious in a low ulnar nerve lesion at the wrist than in a high lesion at the elbow. This is called the ulnar paradox. In a low lesion, the ulnar half of flexor digitorum profundus remains intact. It can therefore flex the distal interphalangeal joints of the ring and little fingers strongly, making the claw more prominent. In a high lesion, the ulnar half of flexor digitorum profundus is also denervated. Distal interphalangeal flexion of the ring and little fingers becomes weaker, so the claw appears less marked despite the nerve injury being more proximal and more extensive. Remember the paradox: the higher the ulnar lesion, the less obvious the claw. Median nerve lesions may also affect the posture of the fingers, but the classic appearances are different. A distal median nerve lesion may paralyze the lateral two lumbricals and contribute to clawing of the index and middle fingers if their long flexors remain intact. However, the classic sign of a high median nerve lesion is the hand of benediction. The hand of benediction is a dynamic sign. It becomes apparent when the patient attempts to make a fist. The index finger cannot flex normally, and flexion of the middle finger is also impaired. The ring and little fingers can still flex through their ulnar nerve supply. A recurrent median nerve lesion produces thenar muscle wasting and loss of thumb opposition. The thumb lies in the same plane as the palm, producing the ape thumb appearance. This is an appearance at rest, whereas the hand of benediction is demonstrated during attempted finger flexion. Clinically, an ulnar claw affects the ring and little fingers. The metacarpophalangeal joints are hyperextended, and the proximal and distal interphalangeal joints are flexed. Look carefully for wasting of the interossi. This causes guttering between the metacarpal bones, particularly over the first dorsal interosseous muscle. Test finger abduction by asking the patient to spread the fingers against resistance. Test adduction by asking the patient to hold a piece of paper between adjacent fingers while you attempt to pull it away. Perform Froment's test by asking the patient to hold a piece of paper between the thumb and the side of the index finger. Weakness of the ulnar innervated adductor pollicis causes the patient to compensate by flexing the thumb interphalangeal joint using flexor pollicis longus, which is supplied by the median nerve. This compensatory thumb flexion makes Froment's sign positive. In simple terms, ask the patient to hold a piece of paper between the thumb and the index finger. Weakness of adductor pollicis produces poor thumb metacarpophalangeal adduction force. The patient therefore recruits flexor pollicis longus through the anterior interosseous branch of the median nerve. This causes flexion of the thumb interphalangeal joint and produces a positive Froment sign. Remember, the sign is not caused by weakness of flexor pollicis longus. It is caused by overactivity of flexor pollicis longus, as it compensates for the weak adductor pollicis. Sensory loss may affect the little finger and the ulnar half of the ring finger. Examine both the palmar and dorsal surfaces. In an ulnar lesion at the elbow, sensation may be impaired over both the palmar and dorsal ulnar aspects of the hand. In a lesion within Guyon's canal, dorsal sensation may be preserved because the dorsal cutaneous branch leaves the ulnar nerve proximal to the canal. To localize the lesion clinically, examine muscles above and below the wrist. In a cubital tunnel or elbow lesion, flexor carpi ulnaris may be weak. The ulnar half of flexor digitorum profundus may also be weak, producing reduced distal interphalangeal flexion of the ring and little fingers. Because this long flexor is affected, clawing may be less prominent. In a Guyon canal or wrist lesion, flexor carpi ulnaris and flexor digitorum profundus are spared because their motor branches arise in the forearm. The intrinsic hand muscles remain weak, but the long flexors remain active. The claw is therefore usually more obvious. Nerve conduction studies and electromyography can confirm the presence of an ulnar neuropathy, help identify its site, assess its severity, and distinguish it from a C8 or T1 radiculopathy or a more generalized neuropathy. When clawing is bilateral, symmetrical, or associated with weakness and wasting elsewhere, consider a generalized peripheral neuropathy rather than an isolated ulnar lesion. Important possibilities include Charcot-Marie-Tooth disease and chronic inflammatory demyelinating polyneuropathy. To understand these differentials better, quickly revise our videos on peripheral neuropathy, Charcot-Marie-Tooth disease, and CIDP on this YouTube channel. In PACES, a suitable presentation would be: this patient has wasting of the ulnar innervated intrinsic muscles of the hand, with weakness of finger abduction and adduction, a positive Froment sign, and clawing of the ring and little fingers. These findings are consistent with an ulnar neuropathy. I would examine flexor carpi ulnaris, flexor digitorum profundus, and the sensory distribution to localize the lesion. Treatment depends on the cause, site, severity, and duration of the nerve injury. Remove or reduce external compression where possible. Conservative management may include activity modification, splinting, physiotherapy, and hand therapy. Persistent compression, progressive weakness, marked wasting, or traumatic nerve injury may require decompression, nerve repair, or reconstructive surgery. An anti-claw splint prevents excessive metacarpophalangeal hyperextension. This places the extensor mechanism in a better mechanical position and allows more effective interphalangeal extension during grasp and release. The memory hook is: intrinsic muscles flex the MCP joints and extend the IP joints. Lose the intrinsic muscles and the posture reverses. The MCP joints extend, the IP joints flex, and the fingers form a claw. Do subscribe to the channel for further videos.